Good morning. Welcome. Nice to have you here in my office. This is Lori Galperin. I'm Mark Schwartz, and we're on 30 Years of Trauma Therapy, Part 2. And I want to welcome you all. Thank you for coming. Today, we're going to be talking from a variety of references. Several of them are listed here for you at the beginning, and you should have copies of it, which will be available to you. And I'll be pointing them out as we go along, but it's instead of you're desperately trying to write them down, just know that you'll have a copy of them. We're from Harmony Place in Monterey, and it's a small partial hospitalization IOP program. We treat 25 to 27 clients who have PTSD and specialize in treatment of eating disorders and chemical dependency and mental health and sexual addiction. So with that, we'll just sort of get it going. So if you followed us from the last workshop, and if you haven't seen that, it's available now on our website for Harmony Place Monterey. You can watch it there. And I'm going to start by just talking about some of the changes that have occurred over the last several years. Obviously, there's been the introduction of complex trauma, and Christine Courtois' book on the treatment of complex trauma is a particularly great book, and she has a new edition of this, which is great. And complex trauma, as you know, is beginning to look at that phenomena of learned helplessness, because many of our clients don't have PTSD, but they have, long-term developmental trauma. Most of our clients really have both. So that changes sort of the model of treatment. So in this first slide, I'm going to try to, for the first 10 or 15 minutes, just talk a little bit about our theoretical lens that we look through. And some of this will be repetitive from the first one, but not really. And in psychology, what we're looking at is what says here, the developmental deviation of the ontogenetic process, failure of adaptations, pattern of adaptation, reflecting the totality of developmental context to that point. That means in the English language is that you have to look at development as sort of a domino effect. The first thing affects the second thing, which affects the third thing. Probably the most robust example of this comes from Alan Sroufe's book called The Development of the Person. And if you haven't read this book, I would call it a must read. It's just breathtaking. And what Alan Sroufe did is he looked at infants even before they were born and then followed them for the 25, 30 years, 290 individuals plus a control group, and was funded by NIH. And he did the strange situation early and then followed them and looked at the effects of early attachment. But in it, what he recognizes is that you can find a trajectory for adult psychopathology. And a trajectory is the first thing affects the second thing, which affects the third thing. So in this work, what he would do is he would find that if there was, let's say, avoidant attachment early in life, then the teachers at school would treat those people different, and the peers in school would treat them different, and then they would do different in terms of grades, and they would then be followed up by adolescent experiences and so on. And so the first event affected the second, which affected the third. So a client may come in and say, oh, this happened to me when I was age 6, but what you don't know is the things that happen before that and the things that happen after that. And so everything affects the individual's development. And so you can then look at trajectory and say, this trajectory seems to be highly related to this outcome. So if you want to say something like, what causes anorexia? That would be a stupid question, because it isn't one thing that causes anorexia. It's a series of developmental events that probabilistically can be related to the development of anorexia. Now, this may sound like a lot of jargon, but in our model, instead of looking at it phenomenologically, a psychiatric disorder is looked at it developmentally. So if a person comes in with depression, I am looking at the sequential developmental events that contributed to depression, not just one event or the PTSD event. It's a more developmental model. And it's essential to know the developmental sequence of events to know how to treat the individual. Because we're heavily looking at a trauma-based approach, meaning that we're looking at neglect and trauma as etiologic variables in adult psychopathology.
One thought I have about that is that the usefulness of thinking about it in that way tends to also be shame neutralizing. I think sometimes people come in and they think, why am I depressed? So much is going right. And after you think about it in this way, and after the client begins to put previously compartmentalized pieces together, it more comes to a point of, oh, well, how could a reasonably healthy person not be depressed? And as Mark said, it also points to the specific things that might need to be addressed in order to have the symptoms remit for more than a few weeks.
Okay. Now, the person that's probably had one of the greater influences on us is Peter Fonagy. And he was at Menninger for a while we were in St. Louis, and he also is at Maudsley in London. And he's an incredible thinker. If you ever get a chance to hear him, I strongly recommend. And in his early work, he talked about what was called reflective function. And reflective function is where the parents are able to reflect to the child's states of mind. So a child comes in and says, the kids at school are teasing me, or the teacher at school is boring. And instead of invalidating that child and saying, what are you doing wrong? What the parent does is they sit down and see the child and begin to reflect to the child how to interact with the world, with people, and themselves, to be able to understand, oh, that teacher, he was my teacher when I was your age, and he was boring then. I can imagine he's boring now. Teachers can sometimes be boring. And here's how you handle boring teachers. Well, that helps the child begin to know how to interact with the world. And that's probably the definition of parenting. Parenting is being present, being able to help the child in the interactions with people in the world around them. Now, the reason I emphasize this is because when we think about trauma, we always think about this terrible thing that happens to a person. But so often, what really affects the development of the child is what they're not getting that they need. One of the areas that again, give you a good reference is this wonderful book by Claudia Gold, which is called The Developmental Science of Early Childhood. And I love this book. I've read it 2 or 3 times. And it reminds us that in order to be adult therapists, we really have to be child therapists first, because it's what's missing from the child and their development that's going to begin to affect the adult. And so more and more what Claudia Gold talks about is the attunement between the mother and the infant and the absence of that. So let me just give you a brief example. One of my clients that's come in is having difficulty in the sense that he's married and he has been having chronic affairs throughout his life, and he's never really had just one woman. And he says that what scares him most is if the woman would leave him, i.e. abandonment, he needs to have one on the side. So when I go back and look at his developmental history, his mother left at age 5 for 2 years, and he knows very little about why she left, and he's asked very few questions. And then she came back, and she was really unable to love him in the sense of what we might call really caring about the child, which we're talking about later. And then when he was a little bit older, let's say 14, she left again. And So he has enormous issues around believing that there's something he needs to do to bring mother back that gets played out when he's in a committed relationship, he gets terrorized. Now, in this kind of a history, you realize that there's no way to treat the chronic affairs without seeing it as a repetition reenactment and an attachment disorder of sorts. And so the idea of that is that there, it was not only that his mother abandoned him, which is the trauma, but it's also the neglect. It's what he didn't get. And so he could sense that his mother was unable to love him. And what is the effect of having, chronic day-to-day activity with a mother who's incapable of loving a child? It's almost an unmentionable kind of thing. It's that we have in our vocabulary. But children sense that accurately, and it has strong effects upon it. So when we talk about treatment, we're not going to just treat the attachment problem from the area of neglect. We're not going to just treat the PTSD of the terror of leaving, but then we have to look at the lack of what was missing. Now, I call that structural deficits. There are structural deficits in the sense that a 2-year-old or a 4-year-old or a 6-year-old or an 8-year-old learns certain things, particularly in knowing that they have a safe home base with a caretaker, and then learn to go out and explore their world and begin to learn self-efficacy and competency. And a child that's terrified to go out and explore the world is not going to learn certain things about themselves. And then they reach adulthood and they don't have those capacities. An example of that would be learned helplessness. An individual won't learn that their efforts can result in change, and therefore they turned into learned helplessness. And so instead of recognizing that they can tolerate the emotions of a person leaving them, they become terrified and they make no changes. So in therapy, what you're doing is teaching them affect tolerance, meaning they can deal with the fact of somebody leaving and tolerate the terror that's associated with it, and self-efficacy, that they can make changes and feel effective and competent. Those core structural schemas are missing. And so it's not just the trauma that you're treating, you have to come in and begin to reactivate those schemas. And we'll be talking about how to be able to do that.
In a related, one hopes, manner, I've been thinking recently about what keeps people from being able to actually look at and resolve things. I mean, obviously, I've had to think about that for the last 33 years of being a therapist. And I think it's black and white thinking and shame-based thinking. So, for example, I think sometimes people imagine that when their child, who may be now adult, comes to therapy, that person is blaming them as a parent for having been inadequate. And what's ironic is that that is really the antithesis of what typically happens. Typically, people are so devoted and loyal to their caregivers that they don't even want to see what was present and what was absent. And so I think a different way to look at it, rather than ascribing blame in any way, because typically what's happened is the person's blamed themselves. What's wrong with me? I had all these advantages. They were really great. They did love me. I knew they loved me, even though. And it just creates a digression that really doesn't serve anyone. So what I would say is, in terms of reflexive function, in order for an adult, or anyone really, in order for anyone to help a child or any other human being with reflexive function, you have to know your own mind, and you have to know something about human relationships in a non-shame-based way. And so that what you can help the child do is to think about things and why people do things, not as an excuse for anything, not as a dismissive sort of thing, but as a way to understand what's happening without simply attributing some shameful deficit to the self, because most things are about far more than just some flaw in an individual. And so it's important, I think, not to think in terms of flaws. And I think a useful way to think about it is Winnicott's notion of the attachment environment. And many people grow up in an attachment environment that, by virtue of all kinds of things, doesn't really create optimal circumstances. I mean, to me, if you think about, for me anyway, 2 generations ago when my grandparents came to the country, I mean, none of them came because, oh, we think we'll go to the US. No, they were fleeing oppression, and they had lots of trauma, which they in no way had time to deal with once they got here, not knowing the language, not having a penny, and not having birth control. So you had a lot of kids, and you had no money, and you didn't know the language, and you didn't know the culture, and you had a lot of trauma that there was no time to process because you were too busy surviving. So I think that generation then tried to create an environment where their children didn't have to go through what they had to go through, but that did not solve the legacy of trauma that then comes into the next generation despite everyone's best intentions, not because of flaws. And so then when it happens in the next generation, that generation says, well, I didn't have it as bad as my parents had it, so what the hell am I complaining about? And in this way, then intergenerational trauma and shame become perpetuated because nobody wants to blame anyone. And in the not blaming, they don't want to actually look at the things that may still need to be resolved within people and within systems. And so I hope that at some point in time, we get to a way of seeing it that allows people to do the work necessary to truly heal.
Now, to bounce off what Lori's saying, that what Fonagy talked about as reflective function became more well known in adults is the concept of mentalization. And when I first heard that term, it was very obscure to me. I didn't quite get it. But it's so fundamental because the mind of self and the mind of others is so critical to functioning. If Lori's over there thinking, oh, Mark doesn't like what I'm saying, then she's going to get very anxious. So the ability to be able to know what's going on with other people and the attunement between them, or if you're highly perfectionistic and I'm thinking, oh, you people are thinking that this is a really horrible workshop, then obviously I'm going to start stuttering and being uncomfortable. So being able to the mind of self and others is sort of vital to functioning. And our clients are incredibly injured in these areas. And so part of the new therapies like dialectical behavioral therapy, acceptance and commitment therapy, emotionally emotionally accelerated therapy. Anyway,
Emotionally
focused therapy. The variety of therapies are really helpful in beginning to fill in the gaps in those areas. See, there it is. Because
you got nervous.
Yeah, I got nervous.
Yeah,
and
you were
see what happens when you don't have it.
Yeah, and does that mean you don't like what I'm saying?
Okay.
No, see, that would be an example of a cognitive distortion, one hopes.
Now, one other thing I want to mention before we move on, which is that these things that we're talking about have really begun to be understood through developmental neurobiology. And so Dan Siegel's work and Alan Shore's work and many, many others are beginning to map out developmentally what's going on in the brain, or at least theoretically what's going on in the brain to some degree. And PET scans and such have really been able to validate some of these theoretical premises. And so, Dan Siegel's idea that neurons that fire together wire together, you begin to understand what we're talking about developmentally in the sense of wiring and top down, bottom up kinds of stuff. Bruce Perry also has lots of interesting things to say about this. For example, when we think about reenactment, what he's talking about is that sometimes what we're talking about as regression is not just a psychological concept, but is a psychophysiological concept. And so it's the prefrontal cortex can shut down and the limbic takes over, or vice versa, when there's trauma. And so what happens is that the person begins to react as if they're a 5-year-old or a 10-year-old, and they don't have access to their adult capacities. And so we're beginning to have some theoretical understanding of dissociation. The lens that we do therapy through has been radically influenced by our understanding of dissociation. Lori and I ran a dissociative disorders unit for many years at Delamo and at River Oaks in New Orleans and Los Angeles, and seeing, really hundreds and thousands of clients presenting with dissociative disorder presented a lens for us. And later, Kathy Steele and Vanderhart and others wrote this wonderful book called Treating Trauma-Related Dissociation. And of all the books that I think have influenced our thinking, this probably is the most articulate of the books that I've read. And if you're looking for one book to read, I really highly recommend this one, because it most parallels our approach, which is that we're looking at the effects of trauma and complex trauma and neglect as creating dissociative states where the person can react in certain situations as if they were not themselves. And so, if I can just say it really simply, the key element for us in working with trauma is consolidating an integrated sense of self. And I always think, that song from Mission Impossible at a time like this, do, 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 because the idea is that how does one consolidate an integrated sense of self in the individual? But you can go back to Winnicott and Kohut and all the self-psychology literature there, and it's just really rich in all of this. And you must, because most of our clients feel like they're imposters. They tend to do what a situation warrants, but they feel this sense of hollowness inside, which I call the addictive self. And so when a person has an addictive personality, they can be addicted to water, they can be addicted to food, they can be addicted to sex, they can be addicted to alcohol. But as you take one away, another one replaces it. And so the mistake that we've made is not really understanding the dissociative nature of the addictive personality, because we treat the alcohol, we treat the eating disorder without really fully understanding that if we don't create an integrated sense of self, there's probably going to be symptom substitution, or one other addiction is going to come up as another one goes down. And so in this incarnation of what we do at Harmony Place, we're treating alcohol, we're treating eating disorder, we're treating sexual compulsivity, we're treating the multiple addictions, because most of our clients have many, and they present with one because the other one's at a lower rate. But we find that most of our clients actually have multiple addictions, and the core of those addictions are in integration. So integration of one's past, present, and future is essential for treating the attachment disorder, and integration in terms of a brain states of right and left-sided brains and dissociative features in the brain itself is essential for recovery of trauma.
I have something to say about that. Let me think how to put it. I'm not sure I would even call this a problem of people with addictive personalities. I think I would call it a problem of civilization at this point in time, at least the culture that I have experienced, which, other places may have gotten to a different state of evolution with this. And apologies if that's true. But I think that there can be a lot of focus on what nature abhors a vacuum. So people fill their voids. And I think often we focus on what particular thing at a given time the person is using to fill the void, which, might not be a bad thing if it worked. But ultimately it ceases to work very effectively and requires more of the same thing or more and different in order to get the salve that ameliorates the emptiness briefly. And so once the addictive behavior of that time frame or the addictive behaviors are more stabilized or there's some degree of abstinence or sobriety, then it's time to really work on what actually got sent away that engendered the original emptiness that the person has attempted to fill, perhaps in varieties of ways, perhaps in ways that are socially acceptable, like workaholism, or ways that are socially somewhat acceptable, like compulsively caretaking everyone else in the world, or like throwing oneself into a given role at the expense of self-development in a variety of directions. You know, that won't get you necessarily thrown into a treatment center. And often when you go to treatment, let's say, I mean, because we're a bit dissociative in our approaches historically, different fields have different philosophies that don't necessarily integrate until most recently with one another. And so, for example, if you go for chemical dependency treatment, often they'll tell you to go to the gym and start working out a lot and eat in a very healthy way. And, you know, you might take supplements. You might become very obsessed and focused on, you know, working out. So you're working out for long periods of time each day and you're eating so healthily that you're really eating in a restrictive way increasingly. And the problem with that is that if you're prone in a direction of an eating disorder, it is the perfect fertile ground in which your eating disorder can pop up to take the place of the original addiction. And so your new addiction is exercise and restriction. And now you're counting calories. Now you're measuring things. And so ultimately, it's kind of like whack-a-mole. And ultimately, if you can get things to quit popping up for a period of time, then you can actually work on the substrate of the emptiness that's beneath that and what actually got sent away that forms that desperate longing for something. And that's often filled with perhaps ephemeral things. Sorry, I have a vocabulary that does that because I was forced to read Reader's Digest and it had how to increase your word power. So I'm not trying to use those words. I just can't help myself. And so that leads to the next slide. I mean, what therapy really involves to a great degree is a person beginning to understand what they kept and identified with and what they banished within themselves. You know how with learning languages, they say it's easier for very, very young children to learn languages because they have the capacity to make all different kinds of sounds and to be able to retain the ability to make those sounds. Whereas in other people's lives, when you're in junior high school, which is what we used to call it, middle school, I guess, and you have to roll your R's because, you know, you're trying to speak Spanish in a reasonable way, it's much harder than if you had learned that language alongside your original English, let's say, at the time that you were a child. So it's like what isn't utilized sort of gets sent off. And the same is true in the sense of the self overall. What isn't valued in the original attachment environment, what won't actually net a person the resources available, such as love and connection and safety as perceived by a child, the child really being a resilient little being notices and without even thinking about it, sends it away as much as possible. And so, for example, children send away all kinds of feelings and all kinds of ways of perceiving reality because they're not really reinforced. And the problem with that becomes if you send away too much of the self, then it's like Swiss cheese. And then, as Mark said earlier, whatever you actually achieve doesn't even feel to many people like a success. They can enjoy like a derivation of their actual self, but something that they're just putting over on people for a period of time, and that will eventually be seen through because it feels not real. And so therapy really involves helping the client be able to reclaim parts of self that were sacrificed in order to feel safety. And attachment is safety. So whatever wasn't valued gets sent, I think, to a psychological dungeon, as it were, and devalued. Then the problem becomes that often that gets passed along intergenerationally, and there's an emphasis on whatever the formulation was originally that created pseudo safety. So if a person thinks, oh, I'll just work all the time and I'll achieve things and I'll prove to whomever that I'm capable, and then prescribes that for the next generation, what often happens, I think, is that the person to whom it's prescribed can feel, well, like Bradshaw said, a human doing rather than a human being, and an object rather than a person. And that leaves the void. So in therapy, as it says here, we do create a context and a relationship where pain and anger and difficulty can be safely acknowledged rather than punished, one hopes, and while still maintaining connection. And if connection is broken, if there's a rupture, hopefully there can be repair, which often was lacking in the original relationships.
When we talk theoretically like this, you're probably sitting there saying, you know, well, how do you do all this? And I wanted to give this theoretical kind of lens of how we look at these things first, and then now we're going to move on to the practical end. But there's one other piece to the theoretical before we do that. If you can go to the next slide 6. And this is a piece from Fonagy's lab. And what you see is the 4 different attachment styles. And he looked at within a general psychiatric population. And again, this slide is breathtaking because what you see is that almost all psychiatric patients have disorganized attachment. And this is the piece that changed everything for me, because I realized that in an eating disorder clinic, instead of treating the eating disorder, I needed to treat the disorganized attachment. In a chemical dependency clinic, instead of just treating the alcohol, we needed to treat the disorganized attachment. And in a mental health clinic, instead of just treating depression, we needed to treat the disorganized attachment. So Lori and I got trained by Mary Main's group in how to begin to work with disorganized attachment. And we happened to do it with Dan Brown, who's our good friend. And he later wrote this book, which is the last book I'm going to be showing you, on how to be able to treat attachment problems. And this is another one of those books that is just breathtaking in the sense that he reviews everything and does an incredible job with it. And he then talks about how you treat attachment problems. And I'll say that as far as I'm concerned, we're not really good at moving people towards their own secure attachment yet. And we have our own way of doing this, which we'll be talking about. But we've borrowed a lot from Dan's work principally. So what I want to say to you is that what one wants to do is begin to understand what is disorganized attachment as a way of treating trauma. And that was the major piece that was missing from our original work. If you go to the next piece, number 7, and this will be the final theoretical piece.
Maybe.
Probably. Ogawa was one of Sroufe's partners, and he had this longitudinal study, and he looked at the long-term effects of disorganized attachment. And it validates so much of what we're going to say from this point on. What he found was that the age of onset, chronicity, and severity of trauma were correlated with adult dissociation more than any other thing. So our clients who have varieties of problems in mental health that we're talking about have a high level of dissociative index. Trauma is necessary but not a sufficient predictor of pathological dissociation. So these things are probabilistically related, they don't cause. both avoidant and disorganized attachment are strong predictors of dissociation. And dissociation in childhood is as a normal response to disruption and stress. So what happens is, in order to be able to deal with, your mother and father screaming at each other every night and then going to school and learning arithmetic tables, you become sort of a virtuoso in dissociation. And the brain follows that in varieties of ways. And so there's a lack of integration in varieties of functions in the brain that are necessary for adult integration. And then dissociation in adolescence and adulthood is a good indicator of later psychopathology. So kids who are smoking dope or spending their heads in their computers all the time as a form of escape are going to develop adult psychopathology with high probability. And that finally, that dissociative behavior shifts in early childhood and disorganized attention more. You get adult attention deficit disorder, and it's then also predictive adult pathology. So I'm sorry to read the slide to you, but the bottom line is I want to emphasize that a dissociative approach to attachment difficulties and trauma is the lens you want to be looking through. And so what we do is we use the parts metaphor. There's a part of you that feels this way and a part of you that feels that way. And remember the original Basque model, BASK, behavior, affect, sensation, and knowledge, Bennett Braun. And when he talked about Basque, there's dissociation of behavior, meaning that sometimes you do things that are outside your voluntary control. Affect, sometimes you go into emotional flashbacks and you become terrified and you don't know what you're scared of. Sensations, sometimes your body reacts with body memories. And knowledge, sometimes your knowledge becomes rearranged. So let me just tell you the robustness of this. Let's say that you get into a relationship with someone who's safe and you have disorganized attachment. You're probably going to get scared to death because it's unfamiliar. And what happens is that a safe person will cause the adrenals to start pouring out cortisol. And so you'll perceive danger when there's safety and you'll move away from people, which is avoidant attachment. On the other hand, let's say you find a partner who's very mean and nasty and rejecting and abandoning. That person will appear safe. Why? Because your adrenals, whenever they're in a situation that's dangerous, do not produce high index of cortisol. So Rachel Yehuda suggested that our criteria for PTSD needs to be the realization that the downregulation of ACTH and cortisol are dysregulated with PTSD. And that is the criteria that we use. So in effect, you have almost physiologic masochism because you end up feeling safe when there's danger and you feel danger when there's safety. And that's a tremendous insight to why it is that people with disorganized attachment, form very dysfunctional, unhealthy relationships that then perpetuate the problem.
So if you substitute the idea, instead of dissociation, which may be different than how you think about things, think about compartmentalization. So, and think about compartmentalization as things like in your freezer. Things are put maybe in airtight Tupperware containers, let's say, and you hear the click and then they're in there until you want to take them out. So the problem with compartmentalization is obviously, as Mark was saying, the lack of integration. So you can't truly bring yourself and all of your vital aliveness to your experience. So how you might have learned to live might be highly just bypassing of vitality and presence. So you might be very high functioning, but feel this inner sense of emptiness and hollowness around your achievements, like it's never really enough for whatever. It never really does what you hope it will do. And so sometimes the way that this can apply to what Mark just mentioned is sometimes a person who has an injury in the sexual realm, some sort of violation or some sort of miserable experience that caused them to feel objectified, even if that wasn't someone else's intention, and a lack of information and tremendous shame. So a person like that can't really be fully present and function sexually unless they bypass and function kind of as an object. So with people that you don't particularly feel as connected to, it may be possible for a person to function just fine. And then the person gets in a relationship that's much safer and more connected and more loving, and all of a sudden finds themselves really just unable to experience sexual arousal. And the other person may think, what the hell is going on here? Seems like a bait and switch. I thought we were like so in love and she or he was so sexual until now. And it's actually something that happens very often and that's very comprehensible if you understand the concept of compartmentalization and functioning in bypass of actual integration.
Emphasis originally was on what was called intrapsychic intimacy, which is one's capacity to form an intimate relationship with another. And what I believe is that the problems that we're treating as adult psychopathology are generally intimacy disorders. And intimacy disorders are usually thought, well, you can't form a connection or feel connected to another person. The problem with that is that there's a lack of ability to connect to oneself, i.e. self-development or intrapsychic intimacy. And so I remember when I went up to Jacobson 25 years ago, and I said, you know, all your work in marital therapy seems to be around forming a relationship with another person. Have you ever thought about seeing the development of intrapsychic intimacy? And he said, what the hell is that? And I think it was reflective of the times, which is that very few people were thinking about how a person forms a relationship with self. But when you understand a dissociative disorder, what you understand is that the parts of self can't integrate because one part knows what another part doesn't know. And until that knowledge is shared between parts, there cannot be some sense of connection. And a disconnection in self usually results in what's a form of self-hatred. If you hate yourself, it's very hard to be loved by another human being. And so we developed this idea that one has to form a secure relationship with self, that the disorganized attachment really means that there's a lack of ability to connect the parts of self. And so disorganized attachment is being able to have parts blend together and work in an integrated sort of way. And so the basis of all trauma work is parts work and having parts begin to dialogue and talk to one another. But now I want to say the most important thing, which is that in processing trauma, what we learned was that talking about the trauma was necessary. Feeling the trauma was also necessary from the vantage point of the adult feeling what the injured part was experiencing at the time. But now part 3, processing trauma means a commitment to taking care of self. Now, think about how profound that is, taking care of self. If a part of self is scared, terrified, overwhelmed, that you're able then to be able to parent that part, to be the adult with that part and reassure that part in some way. And so you're able to access this injured part of self and be there so it's not alone this time. And it's that capacity to care for, to love, to see, and to be with that part that is the key to trauma resolution work.
Let me think how to make it simpler. So, non-acceptance of aspects of self when it's extreme, requires exiling parts of self, which results in self-alienation. And if you're alienated from yourself, you're not just alienated from yourself. That's the problem. If people are like, well, just move on anyway. But you can't exactly move on. And so when you're alienated from yourself, you're not able to receive what resources and supplies, if you will, what love there is to be had. And so when you're alienated from yourself, the problem is you're often also alienated from others and from positive experience. People often think that by having a shield in such a way and feeling estranged from themselves, they actually are protecting themselves. And initially, such things may have started out as a survival strategy. However, ultimately, it's like trying to run a race with one leg tied behind your back. You're really not going to be able to participate as fully as if you were utilizing whatever was available to you in order to do it. And so a lot of people go through life, I think, comfortably numb, as Pink Floyd said. I suppose all of the useful things were said not only in psychology books, but in music of various kinds.
So all this then, now we're ready to move to therapy. Couple comes in with dead eyes and they say, we're bored in our relationship and he's drinking too much, she's working too much, whatever it is. And you can think about, teaching them communication skills and anger management and problem solving and caring days. And in some ways, you're making the objects more objective, you're creating better objects. And so, they can do sexual gymnastics and teach them, sex therapy and all kinds of great stuff. But it's a misconceptualization of the problem. The problem is, he had a mother who was unable to love him and was a mean, nasty client, mother. And, she watched her sister be taken care of by her parents because she had a disability, and she was a parentified child and took care of her mother and her sister, and never got a chance to have self-function. And so the result of it is that there's an emptiness inside. So when the couple come in, you've got mission impossible. You've got to help them develop intrapsychic intimacy, a relationship with self, and interpsychic intimacy, a relationship with other. And that you can use the person's love as a way of seeding that. And so you have the therapist relationship with each, and then you have their relationship with each other, which begins to seed the development of the real self. And so, but the real problem is that when she begins to show love for him, he's unable to receive it. It's sort of like a hormone that can't bind to the receptor site. Her love, he is unable to receive. And so receiving love is an essential ingredient of creating real intimacy. So the point being that what we tend to do is we'll see a couple, we won't see them as individuals, because by doing individual therapy, you end up, just alienating them further. Sometimes. But what we want to be able to do is work with him in the room, work with him, with her in the room, and help do trauma work with her, with him being a witness, and do trauma work with him, with her being a witness, and going back and forth. And then the real intimacy comes from, as they do this depth work, they leave our office and they go out and have coffee for an hour and a half, and they talk about the session and have true intimacy for the first time, intimacy being sharing one's innermost self. And a tremendous amount can happen in that model of intervention.
Let me think. There were a couple things I wanted to just clarify slightly. One is, I think when you talk about parts work, what you want to do is not blend them per se. When you said blend, what you want is to create a sense of acceptance internally in communication among in between, because blending is often the issue, actually. Sometimes we get blended with parts that can't particularly access our current awarenesses and knowledge, and that's what causes us to have sometimes absurd arguments with those we love, wherein we hear ourselves say things and we know we're about to say it and we just say it anyway, thinking, what the hell am I about to just say? No good will come of it. But it's almost like, as Mark said earlier, at those moments, you kind of can't access what's in the other Tupperware container. And so bridging the fragmentation and creating integration and creating self-acceptance just creates, I think, kind of a rebirth of a person. And really, a healing process is no less than a rebirth of sorts. So now, as Mark said also, I mean, a lot of people are extremely good at loving other people, but not so good at loving or feeling empathy for the same vulnerabilities within themselves. And so that creates a problem. That creates often compulsive caretaking. That creates some people going into professions in which they help others unendingly as a substitute for giving themselves the very thing that they're yearning for and truly needed and have never received. And these things have to always be bidirectional in order to not be kind of a workaround or a bypass. But I think that people think, oh, well, if you can go on and devote your life to helping others, then that's great. And I say, if you go on and devote your life to helping others, but stay in estrangement and repudiation of yourself, that's not so optimal. And it's very interesting because people often say, but I treated my children so differently than I was treated. And it wasn't easy, but I really made the effort. And that's no small thing. That's monumental. At the same time, what I often say to them is, on the other hand, though, you still treat yourself with disregard and disdain and put yourself last. So actually, what's getting modeled? And often then there's an imbalance that derives from attempting to heal others without having healed oneself. And there was another thing I wanted to say, but we'll come back around to it as soon as I remember. Oh, self-parenting. So that actually gets us to self-parenting. And when I talk about parenting, I mean heartfelt, self-led, present, empathic, attuned parenting. That's what you want a person to be able to give not just others they love at moments. Well, you actually don't want them to parent other people, but you want them to give aspects of that capacity in relationship. But without giving it to the self, again, there's a limit to what can be brought into relationships.
Let's start with that.
Okay, so we actually talked about this a bit last time, but let's recap. And I'm sorry, there are a few things on here that are not quite precisely typed as stated in Dan's book more articulately, but let me interpret. So when Mark talks about secure attachment really being the foundation and trauma being what then happens to further create difficulty, that's a really important concept, because with secure attachment, a person can go through a myriad of circumstances, many of which may be difficult, many of which may be complex, many of which may be even traumatic. And potentially be able to come out the other end without a lot of residuals, or without a lot of lasting residuals. Why? Because you have the capacity to process, you have the capacity to feel empathized with, you have available to you validation and attunement. If you don't have that, then you can't really process what's happened to you, and it goes into its own airtight container, and everyone thinks, oh, well, they're functioning fine, must be okay, till ultimately when, you have to defrost the freezer and that top accidentally comes off, or when it begins to leak over time and the feelings from it come out, but you don't know where they're coming from. So back to secure attachment, Dan Brown really identified and pared down sort of what are the 5 conditions that promote secure attachment, what are sort of the cornerstones on which you can build a house of attachment, and what are the qualities in the caregiver, parent, whomever, the attachment figure, that allow for that quality to be experienced by the person, so by the child. So the first, he says, is this felt sense of safety, a felt sense of safety. Not just being told you're safe, but the actual experience of feeling safe. And what creates the ability to feel that is caregivers who are protective, not overprotective though, not so protective that they limit your ability to explore your world and learn and grow, but also not lax in being protective in the sense that no one really has your back. And when no one really has your back, a lot of things can happen that are overwhelming and remain unprocessed. So if you think about this, and I know I probably said this last time, think about a mother bear and that kind of protection. Think about an emperor penguin. The second is the sense of being seen and known. And again, I probably will say the thing I always say about this. I think everyone wants to be seen and known until their sense of themselves becomes so weighed down by shame that they're both desperately desiring to be seen and known and desperately afraid simultaneously of being seen and known in the way that they've come to regard themselves. And that's what keeps a person from being able to receive love, because hating the self or degrading the self or rejecting the self, if true love and valuing comes in, it can't be absorbed. It's like the Starship Enterprise and the deflector shields are up. So a person goes on wanting and yearning and needing regardless of what comes in. And then, other people may feel like, what's your problem? You're insatiable. But it's not that they're so insatiable as it is that being able to receive is blocked off. So it's as though internally, when you give that person love and perceive them in a loving way, then there's a part inside that goes, no, not for her, not for him. He doesn't, no. He doesn't warrant that. And so it never is fully received. And again, Harville and Helen Hendricks Hunt have written many books that deal with that, one of which is called Receiving Love. And the thing that allows a person to be seen and known is being attuned to. So you could validate or invalidate, I suppose, without attunement. I see people often who are just endlessly invalidated growing up by someone who was probably themselves endlessly invalidated, and so nobody recognizes it for the problem that it is. But more than validation, I think it's just being seen and known with empathy. And it always makes me think of Alice Miller's quote about a mother only being empathic to the extent that she's aware of her own childhood experiences and non-rejecting of them. Otherwise, her degree of empathy is going to be limited by what she rejects within herself. And, just this week, someone said, I thought that my mother would understand the most because she went through something similar. But when I went to her for compassion about what happened to me, I felt all she did was to point out what I should have done differently, and there was no compassion. And I already felt self-blaming as it was, and after that, I just felt even more alone and desperate and critical of myself, and that was not what I was hoping for. And I really thought about that Alice Miller quote at the time, and how whatever's unhealed in a person, when they see it in another person, often there's a desire, if there's caring, to fix it, to make it right, to help them do what we weren't able to do, let's say. But that winds up being a misattunement because it bypasses the feelings. And this is sort of the famous thing that I think of, the little skit that was, it's like, men are taught to problem solve, not just men now. I mean, a lot of us are also taught to problem solve. And if you're sort of wedded to problem solving, you're going to often be misattuned to a person because what they're telling you, you quickly go to trying to solve for them or help them solve. And there's no acknowledgement of the humanity before moving into assisting with problem solving. So attunement. And attunement is getting into a frame of being able to flow with the other person's experience so that you can, in a way, understand it a bit from the inside out. And I was thinking this morning on the way in that sometimes I think the kind of education we give sometimes is so oriented to facts and figures that when we don't also weave in art, people don't have a way of accessing the reality that some things are common human experiences, and to derive from that solace and the sense of not being alone, even at one's most alone moment.
Okay, so if you sort of, to summarize so far, you're probably saying, well, haven't these people just read Masterson and Kohut and basic object relations? But the truth is that Kohut, in his recent writings, and Masterson, have really come into this new age. If you read the recent stuff, they really have incorporated trauma theory into it and attachment theory. And we're basically reinventing the wheel here. But we're also blending in so many of the other kinds of therapies. I interviewed somebody for a job yesterday, and I said, what's your theoretical approach? And they said, oh, I do DBT. And I always think that when you ask somebody that question, that's the wrong answer, because I don't think a therapist can have one theoretical approach and do effective therapy. I think that object relations is at the basis of what we do. I think that we also do DBT. We also do acceptance and commitment therapy. We also do expressive forms of therapy. We also do affect-based therapies. We also do trauma-based therapies.
Do CBT.
And so on and so on and so on. And what happens as a therapist is you get trained in one thing, and then each year, you increase your knowledge, i.e. you're listening to this workshop, because each of these things that you build upon that increases your competency in dealing with more and more clients. So where we've evolved to at this stage, what we now see is that all human beings carry burdens. And however you want to label those things, those burdens are a certain amount of what Dick Schwartz thinks of as energy that they carry with them that kind of blocks them in certain ways from being fully happy. And so if you go back to Marshall Lanahan's idea that we don't want to just treat the symptom, but we don't want to treat the borderline personality. What we want to do is help a person develop a life worth living. That really is a vital concept, because we're not treating PTSD. We are not treating depression. We are not treating addiction. We are helping a person remove some of the burdens that they've developed, that they have developmentally taken on, that's keeping them from having a life worth living. In that holistic way, it's far more robust, and all those other things are necessary, but they're not sufficient. It says burdens can encompass beliefs, feelings, energetic residue of events and experiences that overwhelm the internal and the external accessible resources of the organism. That's Dick Schwartz's idea, and it's so perfect.
The more complex what you say is, the more simple I want to make it, but I don't want to be reductionistic. So I think all the approaches, the problem is fragmentation. It's not that any approach doesn't have usability. Almost everything has useful pieces to it. And I think for a long time, people want to say, oh, well, that's out now. This is in. It's really not a either or. It's really a both and. And I think it's more like widening the circle of understanding. But any intervention over time, or any orientation, or any approach that doesn't ultimately result in greater self-compassion and self-acceptance, and greater compassion and acceptance of others, is probably lacking something crucial. And I think that maybe what therapy is a rehumanization of a person.
So our job is to do some unburdening, and let's talk about how we do that.
Well, the burdens are the things that block access fully to the self, and that have engendered protective mechanisms for self-protection that, again, make one unavailable to life, and life unavailable and not reaching certain pieces of self. Do you have ego states in here? So ego states is a different term for parts of self. It was used a lot by Watkins, but interestingly, Kernberg wrote about borderline personality disorder as maybe possibly being about the oscillation of ego states and the coming and going without awareness of these oscillating ego states, creating a kind of internal chaos of sorts, where what's happening is hard to integrate and understand and not be sort of carried away on the wave of. So ego states is not necessarily confined to a particular way of thinking. Ego states are aspects, just parts of self, and how fragmented they become can be situational. If ego states are split off or projected or rejected or indulged in an perhaps overindulged way, or otherwise unassimilated, they become black holes that absorb fear and create the defensive posture of the isolated self, or the alienated self, one that is unable to make satisfying contact with oneself or others and others. When split off ego states are made conscious, accepted, and tolerated or integrated, the self can be at one and compassion can be released. So let's give an example of this.
I have one.
Please.
Right. So a client comes in and he says, I was on my way to work today, and a car pulled out in front of me and endangered my wife and child. And I went into rage. I got out of my car and I wanted to kill the person. So I went up, and they locked their door, fortunately, and I started pounding on their door and tried to break their window, and was completely out of control. And my wife tried to pull me back, but nothing could stop me. I was completely enraged. Now, in some ways, that symptom is what I call the gift, because in some models of therapy, that would be thought of as the problem. But if you reframe it as the gift, to me, it's the door into the trauma. It's affect that's out of control. It's an ego state filled with rage that's separated. And he lacks mentalization in the sense that he is unable to have an adult present, and some other part of self has taken over. So we begin to follow the affect. And this is a individual who's been in several deployments, and it would be easy to think of it as he was enraged. And he talks about post-traumatic stress, where he was bombed and almost died. And he comes back in after that and gets no support from his commanding officer and his team. So he writes off the military, wants to drop out, and feels abandoned. So it wasn't even just the event, it was the way people processed the event. And that may be where you would stop at PTSD. But why is it that this perception that his commanding officers were unsupportive was so traumatic? We follow the affect back further, and what we understand is that when he was age 7 or 8, he and his mother were in a fused relationship. Father had left, and the mother went ahead and got into a new relationship with a man and suddenly abandoned him. And he hated this stepfather and wanted to kill the stepfather for taking his mother, and has lots of unfinished business about that. And you might want to stop there, because that probably would help understand why somebody abandoned him would have such an effect. But as we follow that further, what he recognizes is that his wife recently had an affair. And in this affair, he felt like his wife had abandoned him and rejected him. And in addition to that, he realizes that every woman he's ever dated has left him and abandoned him. So you suddenly begin to look at the whole picture of abandonment and see that as the key issue. So what happens is that, anger is his issue, but what's behind it is abandonment, as is true for almost everybody, and that he has never allowed himself to get truly connected to any partner because he's afraid they're going to leave him. So there's the attachment problem. So suddenly we get a whole picture of the burden. So the ego state that was put off, the anger, is a door or a window that we follow and leads us to multiple pieces of work that need to be done in order to both to resolve the anger and to have increased mentalization, so that in the future, when he gets that angry, he can have communication between the adult self and the injured self, or the next time his wife is late, he has communication between the adult self and the injured self, and he can begin to talk to himself. Now we're using acceptance and commitment therapy and diffusion techniques to begin to have internal communication, but those ego states have to be able to work together in order to be able to do that.
There's a lot to say about this. And I keep saying at the beginning of every sentence, driving me kind of crazy. So I think that might sound to people like a process that will take all eternity, but it really doesn't. Actually, being able to discern what's getting activated allows one to go in and begin to work in the arenas that are actually pertinent, rather than just thinking about it in years of psychotherapy, in which the person then feels like they're failing to accomplish much. So
yeah, all that was done within 2-week period.
Yeah. So it sounds complex, but it actually provides a way to zero in. It's like, assessment is sort of like exploratory, and you're trying to figure out where the constraints are within the person, where are the places where they're actually not able to bring in their adult capacities and wisdom, and what's blocking it. And something that's often a blocking factor is when we recapitulate dynamics that feel unfinished in a different time and place in an effort to finish them or have a different outcome, but we don't necessarily realize that we're recreating a there and then situation. And then when the same thing keeps happening, we think, well, what's the unifying factor here? What's the one element that keeps appearing? It's me. So I must just be, to use a non-clinical term, fucked up. And what I would say about that is that many of us, in fact, it's normal and human for people to repeat what feels unfinished or what feels desperately necessary in one place earlier on and project it in the current situation. And the problem is that the past can never be resolved in its recreation. So for example, let's say you felt like a failure and you felt like the one in the family that wasn't so smart, that wasn't so esteemed. But now, as an adult, you've proven over and over again through some acquisition of all kinds of status or all kinds of things that would reflect capacities that, you've actually outperformed everyone. But it's not satisfying. Why is it not satisfying? Because the part of you that feels inadequate is still in there feeling inadequate and feeling like, the Wizard of Oz scene where ignore the man behind the curtain. So that is what keeps people from, I think, living a life that feels worth living, is that degree of separation. So what's sometimes absolutely essential is to be able to go back and get parts out of where they're stuck so that you don't have to have this endless recapitulation of the same theme over and over. And it's been said a lot that, well, not a lot, but it's certainly been said that often problems in relationships between people possibly have more to do with what's getting projected and reenacted than what actually is a lack of love or feeling between the people.
Okay, so what we're then dealing with is subpersonalities and how they interact internally. And in this internal family systems model, which is one of the modalities we tend to use, as well as EMDR, we end up getting different material with different modalities. And sometimes we just do straight Gestalt work, sometimes internal family systems, sometimes EMDR. And usually it's each of them lead to different pieces of trauma resolution. And the idea of that is that you don't try to get rid of parts, but you try to get to know them and understand how they've been protective. And you begin to work with protective parts and look at how they protect the injured exile parts inside. And that oftentimes there are polarized parts. And so what happens is that there's a bit of a civil war going on. And so one part of the individual hates another part of the individual. And it gets played out as a civil war, and therefore it keeps the person from being able to deal with the external stresses that are going on.
Let's give an example of something that's not uncommon. So let's say, for example, a person grows up in a home where they don't really do feelings so much. They kind of do performance, they kind of do activities, but they're not really so into handling feelings optimally. So children have feelings. So let's say the child learns that in order to be loved, if they act like a little adult, that tends to go over better. So they really develop particular aspects of themselves, which are how they manage their life experience as much as possible. And managers are one of the kind of parts that Dick Schwartz talks about in internal family systems therapy. So managers can be, let's say the person wants to be adult and doesn't want to create problems for anyone and wants to act in a mature way, even though they're just a little kid. And let's say they're real smart. So they manage to really do that. And people say things like, oh, wow, he or she, they're so mature for their age. And, you know, that feels good. However, when the child then begins to feel tremendous emotion about something, like tremendous overflow from, say, in the case I'm thinking about, the conflict that's going on between the parents, and they're just unable, they've just gotten to the limit of the capacity of that manager to manage things and be very smart and intellectual and like a little adult. Well, then there's other approaches that come in. It's like a team of managers comes in. They're like your consultants internally, and they're like, all right, here's what we're going to do now. We're going to anticipate every situation before it happens in an effort to have safety and predictability. So we'll just like try to discern what's going to happen before it happens and think about all the bad things that could happen and then how to deal with it. Then that creates a manager that's obsessive compulsive, and it tries to think of every bad thing that could happen and do something to forestall it from happening. However, you're a little kid. So now what you're doing is thinking about bad things all the time and being really scared at some level as you think about not just the things that are going on in the immediate environment, but what it could lead to. So now you're being very mature and you're being very anticipative in an obsessive compulsive way. And then, you know, kids usually bring in some magical thinking to that. So they think, well, maybe if I do this number of times, or maybe if I don't do this, or maybe if I, you know, they try to come up with a incantation and that is how sometimes rituals of counting, rituals of checking are born to try to, you know, I mean, it's like, is the iron still on? I guess people don't have irons much anymore. Let me go back and check 7 times, because even though I realize it was off, I need to go check 7 times. So this is how I think many times obsessive compulsive parts form in an effort to try to create safety in anticipation. But that's not enough either. So let's say then the person takes in some messages from the environment that says, well, performance is really important in this family. And so then they create a perfectionistic part that really tries hard to do everything just right and to get the right grades and to be good at the right things and to just perform like crazy. And so now they have a sort of a management team inside that's perfectionistic, that obsesses about things, and so is obsessive, and a part that tries to be very, very mature and intellectual about things. But eventually they're a kid and the environment is kind of chaotic and they're going to have a lot of feelings. And then when those feelings break through, it's just like an eruption, and it feels raw and it feels powerless. It feels terrible. So that's why the person doesn't want it to break through. And let's say in that home, because the parents are trying like crazy to just deal with their stuff with one another and internally and et cetera, and they're not really able to have much left over, nor maybe were they dealt with in a way that would allow them to have any modeling about how to be a different kind of attachment figure. So the minute the kid flows over and erupts, you know, they're, let's say, sent to their room, either metaphorically or in reality, until they can pull themselves together. So now, you know, a person grows up, they get older and bigger, but their strategies for coping are the same. Their parts are still in there trying to manage their reality. But underneath those 3 managers, as mentioned, actually, is this child whose feelings were constantly invalidated, this child part who has all kinds of raw feelings, and who feels like somehow if they were a different kid, then this wouldn't be happening, because kids always think that there has to be something about them they can change, or else there's not much hope to be had. So when that breaks through, then everybody in a person's environment is like, what the hell is wrong with you? I think you are having some sort of breakdown. And the person again gets sent to their metaphoric room. And in internal family systems therapy, what would be more appropriate would be that the managers could be willing to step back for a period of time, and that then the self of the person, which is not a part, it's kind of the source of actual wisdom and capacity that's often really buried but exists in each person, isn't always easy to access, but is accessible ultimately. The self of the person could be able to create that self-parenting kind of relationship, that empathic attunement, that understanding, and witness actually the feelings and the experiences of that part of self that got stuck in the past in a way that would be sufficient, that if someone had been able to in the original environment, there wouldn't be so much carryover and so much internal division about how to handle things like feelings. And so the person becomes able to witness, and then the part can literally unburden the feelings and the beliefs of the past. And I think that's very hard for anyone to imagine that's ever been depressed and thinks, I'm just doomed. But actually, there are ways that such things, once witnessed, can be unburdened. And literally, it feels as though a literal burden, has been lifted in certain ways. And then new behavior becomes much more possible. And so, often when we're starting out as in a cognitive behavioral way, it can be frustrating when people can't actually do the things we know would help them so much. But the reasons that make it difficult are this interplay of parts, and often the things that need to be witnessed and unburdened. And we all have some, because nobody escapes unscathed. And by nobody escapes whatever, I mean childhood, even in optimal circumstances. And so there are always things that could be unburdened in a way that frees up a person, that creates integration. And then let me say, when that happens, these managerial parts inside that are perfectionistic and obsessive compulsive and have to be intellectual about everything rather than connected, they don't have to be so extreme. And so once that happens, then they too can unburden things, and they become more fluid and flexible, so that the actual talents and capacities of particular parts of self are liberated to assume roles that are more enhancing to the person and to their life and to connection. And that's really what happens.
So let's take the example of the soldier who lost control of his anger. If we access the part that has rage, it's fairly easy to do. It was just out an hour before the session. That is a dissociative part. And so we bring that part into the room. So now we have now accessed the identified client. Instead of client Joe, we have his rageful part brought into the room. How do you do that? You just simply have him remember and feel what happened earlier this morning, and it's very easy to access that. The feeling leads you to the ego state. That anger ego state, we have self begin to talk with that part and get to know it. And that anger part will then begin to reveal some of what it needs you to know about how its anger began to develop and things that happened in the past that might have had similar kinds of emotions and feelings. Now, at this point, we want to begin to move away from cognition and begin to move into affect, because affect is the door into trauma resolution. Talking about it isn't going to be the piece, but beginning to access the injured part of self and witnessing what that part experienced at the time, not therapist witnessing, but the self witnessing, allows there to be sort of a bleeding of affect between the parts. And as that happens, you begin to know, really know, and feel, and really feel. So back then, when you went through the event, you dissociated, meaning that you didn't feel and you weren't really present. But this time you're reassociating, meaning that you really do feel and you really do know, and there's a felt sense of true empathy and compassion. And it's that ability to access true affect and compassion that can allow integration. And that's an essential component for trauma resolution.
Integration of material, not necessarily parts in a way that's obliterating.
Right.
But I'm going to change the term bleeding. Ooh, sounds bloody. No, I'm going to say they're brought into contact with one another. And because let me put it to you this way. If I think about, I'm 60 now. Okay, if I think about what I felt like as a 6-year-old, let's say when I had surgery, and it was a week-long intense experience, and people were supportive and helpful, and nonetheless it was very intense. So probably I put it away. Okay. Now, if for whatever reason it's interfering in some way with my ability to be fully present in my life now, and I come to realize, oh, I wonder if this has anything to do with that, then it would be possible for me to go back and see if there's some part that holds feelings and beliefs around that time. And what could happen is that it's like my capacity, my really, Dick Schwartz would say self-led capacity, which is always within us. But another way of saying it is my current adult capacity.
Wise mind.
Or wise mind, or some people would say, I don't know, it's called a lot of different things. But if that aspect is brought into connection with the aspect of me that really needed something that wasn't able to be emitted by the environment, again, not through anyone's fault, because there can be situations where everyone really does do the absolute best they can do under the circumstances, but for whatever reason, there are places where people can't go because of unhealed things in them, and that leaves a deficit in the experience. And everybody did the absolute best they could, which is why blame is not very useful, but seeing where there's presence and absence really can be. So let's say I go back and I witness what happens that was really overwhelming at the time, but I'm not experiencing it from an aloof position where I'm like, oh, I'm a 60-year-old trying to remember what it was like to be that particular 6-year-old under those circumstances. That's like at least once removed, and it's not going to be like the reality of the situation. However, if I'm just reliving a situation, which is like a flashback, that's not healing. That's actually feeling re-traumatizing, because why would I want to feel what was overwhelming in the original scenario in an unmitigated way? But by bringing together the capacity of calm and compassion, which are self-led qualities, so bringing those capacities together with the feelings at the time in a way that's not inundating, but that's authentic, really allows the part of a person to feel witnessed in a way that they might not have been able to be at the time because there was too much going on or too little available. And literally then it can be unburdened. And Mark, with what you were saying, often I just want to throw in that when you get to the angry part of the person, often that's a manager. And underneath the angry part is a helpless part, and that's the exile. So actually, you might have to go in that case to the helpless exile first, that felt scared when dad left, that felt scared when mom remarried a critical man that wasn't very accepting, and then that felt helpless in those deployment situations and the aftermath of them. And you might find that there's a really, really powerless part, because it's easier to feel anger than it is to feel powerlessness. So often anger is the manager.
That's exactly right. Okay, so the the change in the model is that we're become a catalyst to a process. And so the therapist is no longer the healer, but it's more of a midwife facilitating the birth of what already exists inside the client waiting to be born. And I love that metaphor because what you're doing is you're facilitating an internal process of self-healing. And as that happens, self-healing, the person leaves the session, they take self with them, and there's metacognition. So self can begin to be present for the injured parts and begin to tell them things that they needed to hear back then and to understand. And so instead of using your voice, they're able to use their own voice and begin to understand what happened to them and provide meaning to that. And so the third stage in James Thurman's original concept of healing trauma was making meaning. And the making meaning is done by the self and beginning to get the adult capacities to begin to let the child or the injured adolescent parts know what they needed to know back then.
So with unburdening, the thoughts and the feelings and the residue of the events can be, let out and let go of. But I think that the reason a person might think this is not possible is that without whatever needs to be witnessed being witnessed, it's not possible to unburden. So if you've tried to exile your feelings, well, I tried to unburden that. Well, right, but you tried to unburden it like perhaps others have tried to do with you, where they try to problem solve it rather than being able to be empathic and witness first. And so that tends to be the stumbling block. Now you might be saying to yourself, this parts thing, I just don't know. Does that create parts? And my experience is that we all have them anyway. We're not really labeling them. And you're certainly not asking for anything. You're following whatever has come up. And so literally in the example that I gave earlier, if a person has these two polarized states where on the one hand, they look regressed and crazed and raw and childlike, and they keep getting negative reactions from the people around them who want to push them back into being mature and, put together and composed, then they just swing back and forth for a lifetime and feel out of control. And then it gets called something like regression. And we want to cognitively, restructure them to not behave that way, but to use their tools. That may be useful, but it also can be obscuring and exiling yet again. And so literally what I find is by actually going in and dealing with that part of self and allowing the self to begin to form a relationship and witness what couldn't be witnessed at the time, there really is actually change. And then when the same stimulus situations occur, the person doesn't have the sense that they need to swing wildly like a pendulum out of control between two polarities. It doesn't happen in the same way anymore. And so that's what I think healing is about. It provides alternative options that just aren't available previous to the work being done around the healing and witnessing of the past.
Now, as we talk about the last 30 years, what we learned was that ameliorating the symptom was the first step in therapy, getting under control of it, but was necessary but not sufficient. Doing trauma work was necessary but not sufficient. Working with the internal attachment system was necessary but not sufficient. And the last piece of this was really presenting it from a child psychiatry perspective, using that book that I mentioned to you earlier, the Claudia Gold book. I think we all have to be child therapists. before we're adult therapists and ask ourselves, what is missing when you have neglect or complex trauma? There's a wonderful book called Developmentally Based Psychotherapy by Stanley Greenspan. And what he talks about is the various critical skills and schema that are born along the way. And one of them is self-regulation. 2 is forming relationships. 3 is boundary defining gestures. And 4 is representing internal experiences, mind of self and mind of others. And just by resolving trauma, these structural capacities don't suddenly fix themselves. And so more and more I'm attending to these forms of meta communication and asking what to do about them. One of the ways that I work with that is by using life coaches. You know, after a person leaves treatment in an intensive way, in many ways, they're not cured. What they're doing is now they have to have life experiences that they're able to integrate for the next period of time, usually about a year, that allows whatever it is they've learned to be able to gel. And you can facilitate that process with beginning to articulate what these structural deficits are and provide direct amelioration. For example, one of my clients had an eating disorder. When she left treatment, she would walk and her eyes would be on the ground and she wouldn't look at people and she didn't know how to form social relationships. So if you didn't begin to have a life coach by her side as she left the session and interact with her in the real world, you wouldn't see this. And so you have to be able to assess this. So we developed 360 questions that allow us to begin to assess some of the skill deficits and then begin to work with them one-on-one and trying to be able to do this in a cognitive behavioral way. So if you say, well, you know, I'm a cognitive behavioral therapist, again, we have to be everything. We have to begin to identify these skill deficits, these schema difficulties. And as Jeffrey Young does schema therapy, or in a cognitive behavioral way, you define some of these skill deficits, affect deficits, boundary deficits. So we spend a lot of time. So in our model, we have 6 hours of treatment. We do 3 hours of trauma therapy individually with the therapist, but then we do expressive work, psychodrama, and gestalt kinds of work to get to the affect. And then what we're going to begin to do is skills-based intervention to teach them how to play, how to laugh, how to have fun. You know, children who have to grow up at age 5 don't know how to do those kinds of things and therefore don't know how to enjoy life. So the more we can begin to identify the actual deficits of the individual, the more we can provide amelioration in those areas also. That's why a partial hospitalization IOP kind of program, you know, is incredibly helpful as one phase of treatment for a person with a history of trauma. So I'm just going to read the pieces because sometimes with all this talk, you want to say, okay, let's have a cookbook. So, you know, first thing we're going to do is grounding and containment. We're going to get the symptoms under control, depression, anxiety, etc., using medication, using 12-step work, using a whole variety of cognitive behavioral techniques, and sometimes putting them into a structured program. Then we're going to work with the trauma like we've been talking about today, particularly attending to the repetitions and the reenactments as windows or doors into the underlying trauma. And of course, the ultimate reenactment is marriage. Marriage is always a reenactment of unfinished aspects of self. Eventually, then, to get to the developing a secure attachment with self and others. And we did a whole workshop on that, which you can see on our website. And a lot of emphasis on affect regulation using VBT, affect tolerance, affect regulation modalities. Then beginning to see the development of the self. Sometimes individuals have a poorly differentiated sense of self. In those cases, what we're going to do is begin to get parts to step back and allow more and more self to be able to unfold. and then the skills orientation that I was just attending to, and then finally helping them find a partnership and begin to use some of their skills to develop intimacy, and finally sexuality, which is what we're going to talk about in the next workshop, because sexuality is usually the last phase of working with trauma.
I just, you know, if Dick Schwartz ever listens to this tape, he'll just correct you and say that the self doesn't have to be seated. It's in there. It has to be accessed. And sometimes there are many, many layers over it that make it more complex so that a person doesn't really know it's there, but it's there. But different approaches categorize things in different ways. That doesn't mean that the underlying truth is necessarily lost by the difference in how it's conceptualized.
Well, it unfolds in the concept of being seen and loved. And finally, integration. I'm back to 1981, where Horowitz originally started us in stress response syndromes. And we have to look at what are our criteria for when trauma is integrated. And this slide just lists some of those pieces and allows you to sort of have a checklist and be able to determine. If you find the person still depressed, then you know that there's still layers of work that need to be done, for example. If you find them repeating destructive transactions, you know that there's still more work to be done. And so you get back to Francine Shapira's idea of channels, that usually one channel of trauma leads you into the next channel of trauma. And trauma can't be fully resolved until you've sort of drained the multiple channels that are contributing to the response. And so it's not uncommon that you can do a good piece of work, but not get trauma resolution because you're flowing into another channel that has not yet been dealt with.
Yeah, so you might think, wow, that just sounds endless. Well, I would say the process of rehumanization of oneself could be endless. That doesn't mean that therapy has to be endless, because what happens is that the more that gets cleared out that's been acting as an internal impediment to feeling connected up inside, the more that's unburdened, the more self-energy flows, and then the more that can be unburdened, and then the more self-energy flows, and the more a person's capacities come back online, and the more feelings without their burdens become accessible without the fear that accessing a certain feeling will also bring with it horrible feelings that got layered on top of it. So, for example, sometimes a person's most loving and vital feelings or parts of self, when they're met with shame and rejection, get really laden with all kinds of feelings of shame and self-disgust. And without the shame and self-disgust that were burdening those parts, there can be a renewed aliveness that, again, makes life worth living. So it's not just about healing trauma. It's about actually, again, allowing aspects of self to re-emerge in ways that often the person thought were not going to ever be possible. And so a person really begins to have more access to doing the work within themselves on many occasions, and using therapy more like a 20,000 mile checkup for a car. And I think another thing that really is crucial here is the peer group that becomes possible, and just the group in general, because I think that the neutralization of shame and the mitigation of the aloneness that accompanies trauma is really best done by the presence of a supportive, empathic community. Also, I know that I've run across people that have misconceptions about therapy and think that therapy is going over and over the same material. I mean, people go over and over the same material because it's not metabolized, resolved, integrated, and able to be moved on from. So I think what you find is that people with preoccupied attachment patterns may continue to go over and over and over and over and over material. That's not about resolution, that's about a lack of resolution. And so in our culture, we prefer the other polarity, which is avoidance. And the philosophy is just, well, pick yourself up by your bootstraps and just move on. So avoidance is about avoidant attachment patterns, and avoidance and preoccupation are two sides of the same coin that indicate actually a lack of resolution. Resolution is about something entirely different that allows a person not to be locked into a managerial pattern of either avoidance or preoccupation. And that makes new and different things possible, new and different relationships with self and with others. That's what I got.
Well, let's see if any of you have questions. Does DBT actually teach regulation of emotion? Surely. I mean, affect regulation is the core of DBT and affect tolerance. And if you've been trained in DBT, you're really good at it.
I think they're, like anything else, there are people that do DBT in different ways. And so you might have been to a group and you're like, that wasn't helpful, but there could be other DBT groups that would actually be helpful. Same with 12-step groups. I think, just as a thought, in early recovery, I think 12-step or something comparable, some sort of group situation is incredibly useful, but you may have to find the group that works for you.
Any other questions? Dr. Dan Brown has said only mindfulness with DBT. Well, if Dan Brown says it must be true, because Dan Brown's a genius. So if he likes mindfulness with DBT, that makes sense. But if you think about it, Marsha Linehan was really trained with mindfulness. I mean, she worked in Eastern philosophy, is where the basis of that came from. So I think mindfulness is really the key to working with DBT anyway.
Yeah, I mean, it may be teach affect regulation that's actually the issue. It may be that affect regulation is the result of increased mindfulness. Maybe that would be more accurate.
Okay, well, thank you all for attending, and I hope to see you in our next webinar, which is going to be really good because I'm going to use all the Masters and Johnson stuff that's not been published and apply it to working with trauma cases.
And I think Mark's going to be doing that one on his own because I think I'm out of town then. But thank you very much for your attention, especially on a Friday. And I wish you all a good and enjoyable weekend.
Bye-bye.